Good evening. Meeting मी चालू आहे माझं तुमचा आवाज येत नाही आवाज करता आवाज नाही हा एवढंच तर चालू मीटिंग आणि बाकी तुम्ही आले नाहीत ना
कनेक्ट हुआ कनेक्ट
आत्ताच चालू झालंय मी चेंज करतो
Hello, good afternoon, everyone. I am Dr. Aisha Harris. I request you all to please fill the pre-webinar survey that is in the box present and also present on your screen. There is a QR code mentioned and a link. You can choose any of the two and fill the pre-webinar survey. I would also tell you that there is a post-webinar survey as well, which you would be required to fill. I would request you to fill both the surveys in order to get your certificates. Thank you. We will be starting the webinar shortly. Once again, I request you all to please fill the pre-webinar link. It is very well visible on the screens and also in the question and answer box. I request you all to fill that, please. It will just take 2 minutes. To welcome our host for today, the United Way Mumbai, I would request Dr. Umesh Kapil to welcome the host and Dr. Shailesh Wagle. Dr. Umesh Kapil is a professor and head of Department of Epidemiology, Institute of Liver and Biliary Sciences. He is an academician and educationist par excellence. He has more than 4 decades of experience in research and teaching, led numerous funded research and demonstration projects. Sir has published widely in more than 340 publications to his credit, and he has been the member of National Task Force of ICMR, BIRAC, and DBT. Sir is the Regional Counselor, Southeast Asia International Epidemiology Association from 2021 to 2024. He is also a recipient National Award for the year 1992, BC Srivastava ICMR. He was also awarded for the year 1996 MK Susadri ICMR, and also received National Award for the year 1996 P.N. Raju ICMR. He is identified amongst the 2% of global scientists for research contribution in the field of child health by Stanford University, USA. Over to you, sir.
Good afternoon to all of you. My most sincere thanks to all the participants who have joined this webinar. My special gratitude to Dr. Shailesh Wagleji uh, from United Way, Mumbai. We are very happy to be a collaborator with your organization. We understand that you have an important project on United Against Hepatitis. Honestly speaking, hepatitis, we have never been able to get so much of importance as it deserves. If we look at the common mortality which is being caused due to hepatitis, it is much more than even if we combine the total deaths due to malaria, tuberculosis, and HIV. Somehow, HIV has been receiving much more attention at all the levels, national level, state, district, and even the political level and the bureaucracy, possibly because a large amount of funding is available on prevention and control of HIV, and possibly this HIV agenda was promoted, or maybe I can say thrust upon us through the developed countries on our poor countries. If we look at our country, we have about 4% of the population who are suffering from HBV infection. And there is a very small amount of treatment available. Once a person becomes HBV positive, he continues to be lifelong once if he has a chronic HBV infection. Similarly, if we look at hepatitis C, about 1% of our population suffers from hepatitis C. We are lucky that we do have a good treatment available for HCV, and by 3 months of continuous treatment, we are able to get a complete cure, nearly a cure. That is, the virus load becomes very minimal, and person can lead his normal life. Now, these are the important issues related to hepatitis B and C. Now, ILBS has been undertaking a pioneer research and services in the field of hepatitis B and C. In fact, all the 5 viral hepatitis A, B, C, D, E. And we were very much instrumental in convincing the government of India that we need to have our national viral hepatitis control program. And under the leadership of Professor Sareen, we ensured that the government of India undertakes or initiates the national viral hepatitis control program in our country. And now this program is very successfully being launched or being implemented in the entire country. The purpose of these webinars is essentially that ILBS have a community outreach activity, and under the community outreach activity, we try to disseminate information, knowledge, and awareness about hepatitis B and C. We would be focusing during the next 2 hours about how we can prevent the hepatitis B and C. And I'd just like to share with you hepatitis B and HIV both have almost common modes of transmission. They are transmitted through contaminated blood, they're transmitted through unsafe sexual practices. So these are the important issues which we have. And there's a need that we should educate our youths, particularly, about these precautions to be undertaken. Now, hepatitis C is also being transmitted sexually, but more common method of transmission is essentially through the injections. And it's quite common amongst the injectable drug users. And if you look at some of states where the injectable drugs are being used, like in Punjab, like in northeastern states of our country, we have a very high prevalence of hepatitis C. Now, we would like to have some of our colleagues would deliver state-of-art presentation, and we request all the participants to ask their questions. We'll try to respond to them. And if there are any other issues related to these topics, please do write to us. And we would like to get collaborated with United Way Mumbai in our future endeavors also. And if you need any help or assistance, please do write to us. We'll definitely undertake this joint collaboration. With these few words, I would again like to welcome all the participants, all the speakers, and thanks to Dr. Shailesh Wagle for organizing this important webinar. And we hope that the knowledge gained from the experts' presentation, people would like to take it up and at least in their own life and in their family setup, they will try to implement it so that they are able to help in our efforts of prevention and control of viral hepatitis. Thank you very much. Bye. Namaskar to all of you. Over to you, Dr. Aisha.
Thank you so much, sir, for your warm and very informative words. And it is indeed a pleasure and an honor to be organizing this webinar alongside United Way Mumbai. Before we move forward, we welcome the participants who are also introducing themselves in the chat box. We request kindly locate the link posted, which we will share right now in the chat box itself to access the survey form. It is mentioned as link 1, that is for the pre-webinar survey. I would like to again tell you that there will be a post-webinar survey also. I request you to fill both the surveys in order to get your certificates. Thank you. Moving on, I would like to request Dr. Shailesh Wagle, our keynote speaker for today for United Way Mumbai. He is the manager under the Community Investment Department. Dr. Shailesh currently manages the health and livelihood verticals at the organization and excels in program management, handling budgets, preparing proposals, team management, and public speaking. He has previously worked in the areas of urban health and climate resilience in Surat. He holds a bachelor's degree in Ayurvedic medicine and surgery and master's in public health. A warm welcome to you, sir.
Thank you so much. I hope I am audible. Hello?
Yes, sir, you're audible, sir.
All right, great. So good afternoon, everyone. The entire team of ILBS, all the college students, the team from United Way Mumbai, and everyone who has shown interest and taken time to participate in this webinar. I would like to quickly introduce you to United Way Mumbai. We are a non-profit organization based out of Mumbai and part of the global United Way movement. As part of the health and especially the hepatitis focus, United Way Mumbai has been working for past 12 years with the communities, with the vulnerable population, those who are more prone towards a needle prick injury or unprotected sexual activity. So we have been working with these vulnerable communities for past 12 years, and what we have understood is that the knowledge about hepatitis B among the community and among the population is extremely scarce. You don't really see people talking about hepatitis B, even though the prevalence of the disease is much higher than many other diseases, and this being a non-curable disease. So the idea of doing this webinar is to set a path for our college youth or healthcare workers to understand this viral disease, which can lead to a fatal complication. But at the same time, it is very easy to prevent yourself from getting hepatitis B infection. United Way Mumbai has been working not only towards creating awareness, but also providing the necessary medical interventions such as testing and 3-dose vaccination, and also uh, treatment and consultation to those who are identified as hepatitis B positive in the public hospitals by creating linkages, by setting up meetings with the experts in the public system. Uh, we are extremely happy that ILBS and United Way Mumbai can work out in creating this wonderful webinar, and we have been interacting with ILBS quite extensively on this, and we understand that this will not be just a webinar for the student, but this will be something that is an eye opener, because you are at a age where you are most vulnerable. This is the adolescent and the early adult age is where somebody is very prone to getting the hepatitis B infection. Uh, from United Way Mumbai, we have till now worked with more than 8 lakh individuals, sensitized them, made them aware of what the infection is, and we will keep continuing our efforts, towards sensitizing the entire city, the entire country. Our efforts, our time, our focus is there with all of you, and I wish all of you a very best of luck. I request all the students to please pay attention, share the information with your loved ones, with your parents, with your siblings, with whoever, your friends. Make people understand that there is something uh, that is still a threat, a public health threat to all age groups. It is not something that happens only in young age or only in old age. Hepatitis B, hepatitis C can happen at any age, and the vulnerability is equally high. So I would request all of you to please pay full attention, ask questions, get your doubts clarified, because this is a great platform for you to learn about a disease that you probably have not heard of. So best of luck to the ILBS team, best of luck to the United Way Mumbai team as well, and all the colleges and everyone who's here. I wish you all the very best. Thank you.
Thank you so much, sir. Thank you for taking the time out from your busy schedule. Your presence and wise words help magnify our cause in the best possible way. It is very heartwarming and a delight to see a wide number of participants that are there today in the webinar. I would also request you to kindly pause it for the intro with your introduction and kindly fill the survey and help each other to locate the link which has been posted time and again for the pre and post webinar survey. For now, it is a pre webinar survey. And as Sir said, there are going to be very engaging and very enlightening sessions that we will have from our eminent speakers. And there's a Q&A box in the Zoom. You are all encouraged to ask questions, be it as simple or as complicated. Our speakers are always up for answering all the questions which are there. For the first session, I would request Dr. Manya Prasad to take the session. Dr. Manya Prasad is the Assistant Professor, Clinical Research Epidemiology, ILBS. She has 35 international and national articles in medicine index journals. of interest are epidemiology, medical research, systemic reviews, and meta-analysis, evidence-based medicine. She has been facilitated by many workshops on research methodology, evidence-based medicines, and GRADE tool. She is a gold medal in MD final exam. She is also the recipient of International Epidemiology Association Fellowship. Over to you, ma'am.
Sorry about that.
Ma'am, I think you're still on
Thank you so
mute.
much, Aisha. Yeah, I think you can hear me now. Yeah, okay.
Yes, ma'am, you're
So,
audible. I'm listening.
I extend my heartfelt gratitude to United Way Mumbai for jointly collaborating with ILBS on this national webinar on hepatitis C and C. And it's so heartening to see how United Way Mumbai has left a mark in public health efforts against diseases of public health importance, including hepatitis. And it's extremely heartening also to see all the participants that have joined us here today. Thank you so much for taking out the time to participate. And without much ado, I think I'll get right down to the presentation. And what I've been asked to talk about is the current disease burden of hepatitis B and C in India. So what this will contain is reported estimates of the prevalence of chronic hepatitis B and C in India. I will do a critical review of the current literature and provide estimates from recent studies. So this will be a little bit of an academic discussion, but I will also bring about the limitations in the current literature that's out there. Further, I will talk about the rate of liver complications with hepatitis B and C and finish with some steps needed. So needless to say, the liver is a very important organ in the body. It's situated right here in the right upper quadrant of the abdomen. And it basically is responsible for a whole array of functions, works day in and day out, and performs this whole range of metabolic functions. It's a metabolic factory, really. What damages the liver is basically three things. The first is alcohol, which is probably the most talked about risk factor for liver-related morbidity and mortality. The next is fat. So fatty liver disease, also called non-alcoholic fatty liver disease, is set to become the leading cause of liver-related morbidity in the future. So another very fast-growing cause, in fact, fatty liver disease is the most common chronic liver disease in the world. So another very important factor for liver damage population-wise. And the third major cause is viruses, which will be the focus of the discussion today. And apart from these three things, there are some very rare causes of liver damage, such as autoimmune diseases and so on. Now, there are 5 types of viral hepatitis, just like the 5 fingers in your hand, A, B, C, D, and E. I think Dr. Kaneka or Dr. Kaushal will talk more about the types of hepatitis and their transmission. But just suffice it to say here that A and E are transmitted through food and water, contaminated food and water. And B, C, and D are the viruses that have parenteral transmission, so blood-borne or sexually transmitted, and so on. So why do we need to think about hepatitis now? Well, because it's one of the leading causes of mortality worldwide. And it's certainly a very important cause of mortality in Southeast Asia, which India is a part. It's a communicable disease where mortality was observed to be increasing. So while deaths due to TB and HIV had a reduction in trend from 2007 to 2017, which was reported by the WHO. In contrast, hepatitis mortality did not observe a decreasing trend. In fact, it was increasing. And it's responsible for as many, if not more, deaths annually than TB, AIDS, or malaria. And around 90% of these deaths is due to hepatitis B and C infection. We also need to think about this very seriously, because this is a disease that's amenable to prevention and control. So we have a very, very effective vaccine for hepatitis B, extremely effective. You hear about, COVID vaccines having 70-80% protection efficacy, and over here we have a vaccine that's more than 95% efficacious. And for hepatitis C, we actually have a cure now. So this is something that we can actually do something about. And so it's about time we turn our attention to this important disease. How has the COVID-19 pandemic influenced elimination efforts for hepatitis? Well, the pandemic has posed a major challenge in achieving hepatitis elimination. And best by interventions like vaccination and health education and screening was severely interrupted during the lockdown and continue to suffer, that slow pace currently as well. And it's been documented that hepatitis has suffered amongst the highest destruction of all diseases. And this is more than that for even HIV, malaria, and tuberculosis. And in fact, the previous hepatitis day that was observed on July 28, 2021, the slogan was exactly this, that hepatitis can't wait. So while we have to ramp up efforts to other communicable diseases like COVID-19 as well, but it's about time we again turn our attention to hepatitis, because this is something that cannot be ignored while we detract resources to other diseases. Now, when we talk about the burden of disease due to hepatitis, what is important to know here is that we are also worried about the burden of complications. So, this is a healthy liver, and then it's infected by viruses like the hepatitis virus. Sometimes what happens is that there's an acute disease. So there's fever, malaise, jaundice, and the patient recovers in a few weeks. That's acute hepatitis, and the patient goes on to become normal in a few weeks. However, with hepatitis B and C, what happens is that the infection lingers on in the liver. So, for many months, years, the hepatitis virus continues to cause damage in the liver. And this is called chronic hepatitis. So this is inflammation that lingers on for many months and years. And with this long-standing inflammation, what happens is permanent damage to the liver. And this is in the form of replacement of healthy liver tissue with scar tissue. So scar begins to form within the liver, and this is called fibrosis. And with long-standing fibrosis, the liver actually becomes cirrhotic. So this is called cirrhosis. This is irreversible damage to the liver. And with long-standing cirrhosis, what is caused is hepatocellular carcinoma. So this is liver cancer. And so when we talk about the burden of hepatitis, what we are really concerned about are these very important complications that are responsible for majority of the morbidity and mortality with hepatitis B and C. And so we're worried about liver cirrhosis, which is a very expensive disease to manage, which is one of the most common causes of liver transplantation worldwide, and of course cancer. Again, a very difficult disease with high mortality and morbidity. So coming on to the numbers, if we talk about the worldwide prevalence of hepatitis C, well, there are 296 million people worldwide living with chronic hepatitis C and 68 million with chronic hepatitis C. According to the WHO estimate of 2015, viral hepatitis accounted for around 1.4 million deaths worldwide. And it is estimated that hepatitis C resulted in an estimated 820,000 deaths. And most of these were from cirrhosis and hepatocellular carcinoma, those two complications that I talked about in the previous slide. With regard to these liver complications, cirrhosis and HCC, up to 40% of patients with chronic HCV virus develop serious sequelae in their lifetime. And HCV and HCV infections with cirrhosis accounts for 720,000 of these deaths, and hepatocellular carcinoma for 470,000 of these deaths. So you can tell the big numbers here in terms of morbidity and mortality. So this is how the numbers are spread across various WHO regions. The total is 296 million. And then you'll see here that there's a gradient with regard to the WHO regions, with some regions suffering a greater burden. So you can see Western Pacific region, African region, very high burden, but also Southeast Asia, 60 million cases of chronic hepatitis B. For hepatitis C, again, we have 68 million worldwide. Again, there is this parity across WHO regions with 10 million cases in Southeast Asia region. Also, within the Southeast Asia region, there is a gradient with regards to the burden. So there are some countries that suffer a greater burden. The way that we measure burden of hepatitis C is by detecting the surface antigen. So that's how the prevalence of hepatitis C is calculated. And so we have countries like Bangladesh, Indonesia, Thailand, Myanmar, which have a high burden of hepatitis C, and also consistent with this is hepatitis C prevalence. Again, we have some countries that are suffering more. Majority of this discrepancy is due to differences in mother-to-child transmission. So what is the estimate for India? There are three research groups that have reported the prevalence of chronic hepatitis C infection in India. And these are the three groups. The first was the paper by Schweitzer et al. This was published in the Lancet in 2015. We have the WHO estimate, where the WHO has engaged a number of agencies to arrive at the estimate. And then there's the CDA Polaris group. So what you will see in the middle over here, this number is the point estimate. So you can think about this as sort of the best guess from the available data. And then in the bracket, you have the confidence interval. So this you can think about as sort of the margin of error. So what is the margin of error? You can see today we have election results. So, sometimes you'll see that surveys, they report that, so-and-so politician has 60% popularity, and then they say plus minus 5%. So this margin of error is what you can think about as the confidence interval. So the estimate is 1.46, so around just under 2% for hepatitis B through measurement of surface antigen. And you'll see that there's significant overlap in the confidence intervals of all of these three estimates. CDA Polaris group had slightly higher, but again, significant overlap. If you're wondering how these research groups arrived at the estimate, they've all synthesized evidence from existing literature. So they've looked up databases and they've synthesized it in the form of something called a systematic review and meta-analysis, which is basically a study of studies. So they have summarized the estimates from peer-reviewed literature, and some groups like the WHO and CDA Polaris, they also included unpublished literature. If you're wondering why the discrepancy, well, this could possibly be because they enroll different countries, slightly different kinds of populations. Most of them excluded high-risk populations and non-representative populations, but there were some differences in the kind of people that they enrolled to study. So this is purported to be a good estimate, 1.46% from the Schweitzer et al. Paper, which included 129 studies and 3.7 million subjects. This accounts for an estimated 17 million chronic carriers in India. And if you compare two time periods, you will see that if we talk about 1950s to 80s and compare it to the decade later, there has been a reduction in the prevalence of hepatitis B. So the trend is that there is a reduction in prevalence of chronic hepatitis C, and this can mainly be attributed to vaccination, universal immunization, which has a hepatitis C vaccine in the schedule. And if you look at the WHO estimate from the pre-vaccination era and compare it to the 2019 estimate, again, you'll see that the reduction is reflected here as well. And again, this can possibly be attributed to vaccination. In terms of recent studies, all of these, the next 3 slides are recent studies that have been conducted on the prevalence of hepatitis C. What you will see here is that, there is a lot of heterogeneity with regard to a lot of things. So the population included in the studies ranges from general population to patients to eye donors and blood donors, etc. And they're also differing in their testing methods, which could possibly be responsible for the discrepancy in the estimate that we reported. So what you can tell from here is that there isn't a very credible nationally representative survey that can provide us with a very good estimate. Recently, there has been some nationally representative surveys which still have to be subjected to critical appraisal. But this is the recent literature that's there. For a prevalence of chronic hepatitis C, this is again a systematic review, which if you take the estimate from community-based studies and those in general population, blood donors, and pregnant women, the prevalence estimate is 0.85%, which accounts for up to 12 million chronic HCV infected persons in India. And also there are 3 to 9 million persons with active HCV infections, and hepatitis C accounts for up to 32% of hepatocellular carcinoma and 20% of cirrhosis. So huge burden there in terms of liver complications as well. So as you can tell, there are some limitations of the current literature. The quality of reporting is highly variable with both representative and non-representative studies that have provided the estimate. There is paucity of data on age-specific and sex-specific estimates. So if you ask me, is there a signal with regard to gender, modifying the prevalence? We don't know because we don't have that kind of data. Healthy donor effect, some of the studies were done in blood donors, which could possibly be healthier people, and that could be an underestimate. And most of the studies are in subnational level, and some have targeted very high endemicity areas like tribal. So lastly, let me talk about the mortality from hepatitis B and C. And what this graph depicts is the number of deaths in HPV and HCV that can be attributed to cirrhosis and hepatocellular carcinoma and acute hepatitis. So this lightly shaded portion is the deaths from hepatocellular carcinoma, and the slightly darker shaded one is the death due to cirrhosis, and the very darkly shaded one is acute hepatitis. So you can tell here that most of the deaths, huge chunk actually, is because of cirrhosis and hepatocellular carcinoma in both HCV and HBV. And if you're interested to know about the absolute numbers, this is the age standardized death rate. So that's the number of deaths per 100,000. And you can tell from here that liver cirrhosis due to hepatitis C, again, huge number, 141,000 estimated deaths, and that's 7.8 per 100,000 as a mortality estimate for India. This was a paper that emanated from the Global Burden of Disease study, which talks about the incidence rate of cirrhosis and hepatocellular carcinoma due to HPV and the death rate from those two complications. What is worrying here is that, if we compare the 2007 to 2017 percentage change, and for the global, at least the point estimate for the global estimate is a reduction, so 2% reduction, whereas for India, the point estimate suggests an increase. But then again, the confidence interval suggests that this is not a reliable estimate. And when we talk about the death rate again, the point estimate points towards an increase. The big caveat here is that this relies on a cause of death certification, which is very poor for India. But again, we need to delve into this a little deeper. And then this trend also holds individually for liver cancer and for liver cirrhosis. So, taking into account all of these, major threats that's there due to hepatitis, the World Health Organization, they came up with the Global Health Sector Strategy on Viral Hepatitis, and this aims for viral hepatitis elimination, which aims for a 65% reduction in deaths due to chronic HPV and HCV by 2030, and a 90% reduction in new cases of chronic HPV and NCV by 2030. So this is what elimination entails. And the only way that this can be achieved is by a public health approach. We need the concerted efforts of all kinds of public health agencies, including NGOs and state-of-the-art research institutes and medical colleges and government agencies that are involved in the public health approach. And that's, I think, the only way that that goal can be achieved. So thank you very much for your attention, and please put in your questions on the Q&A feature of Zoom, and we'll be happy to try and answer them. Thank you very much. Over to you, Aisha.
Thank you so much, ma'am. Thank you for such an informative presentation. The numbers are, yes, very overwhelming, and hence imposes a major public health challenge and requires for an urgent call of action. Our next speaker for today is Dr. Kaneka Kaushal. Dr. Kaneka Kaushal is an assistant professor of epidemiology at ILBS. Before recently joining ILBS in October 2021, she has worked as technical officer at South Asia Field Epidemiology and Technology Network, SafetyNet, an international organization funded by United States Center for Disease Control and Prevention, Atlanta, US, for India Epidemic Intelligence Service Program, EIS. She managed the India EIS program for National Center for Disease Control, Delhi, and worked actively in various COVID-19 related outbreak investigation and surveillance activities since March 2020. She has worked in the digital health space during her tenure at PGI-MER, Chandigarh, where the team successfully helped set up electronic health records in a public health dispensary from scratch in collaboration with HISP India for outpatient services to the slum population of Chandigarh. Ma'am has also implemented smart technology in a small village of district Panchkula, Haryana, where they check the feasibility and utilization of mobile phone-based smart technology for chronic hypertensive and diabetic patients in a resource-constrained setting at a rural healthcare post in North India. She has published over 50 research articles in various national and international journals. I welcome you, ma'am, for today's webinar. Well, good afternoon, everyone. So, learning objectives of my today's topic will be to tell you about the modes of transmission of hepatitis B and C and strategies for prevention of transmission. So the general precautions for Hep B and C and vaccination and PEP for hepatitis B. Vaccination part under prevention heading will be taken by Dr. Tushar in detail, but I'll just walk you through this particular subtopic. So hepatitis viruses, these are hepatitis A, B, C, D, and E. So hepatitis A and E virus, these are enterically transmitted by a fecal-oral route where we consume the bad food or water. And hepatitis B, C, and D, these are parenterally transmitted, as you will see in the next slide. So either they are blood-borne because of blood or blood products transfusion or other nosocomial routes acquired in the hospital, that is if the patient is undergoing dialysis, unsafe injections, needle stick injuries, certain dental procedures, surgical procedures, and organ transplantation. Then sharing of needles among persons who inject drugs, then sexual route transmission, perinatal, that is from mother to the child if mother is hepatitis B positive, then vertical transmission from mother to child, and then horizontal transmission in a family household context. So first I'll discuss hepatitis B virus, so the routes of transmission, and then we'll jump to hepatitis C virus, routes of transmission. So starting from perinatal, that is mother to child transmission, and then these are, as we have discussed, these are the healthcare associated. So these are in order of like the major transmission is from mother to child, and then the horizontal transmission, and then healthcare associated, as we have discussed, then unprotected sexual intercourse, and then the sharing of the needles among people who inject drugs. So infections during infancy and early childhood are particularly, they are likely to lead to chronic infections with risk of cirrhosis and death. So owing to this is a guide for introducing and strengthening hepatitis B birth dose vaccination. So if you can see here, like as this is the chronic infection. So infection during early infancy and early childhood, if they are acquired, so the chronicity, the chances of chronicity are more here. So the chances for chronicity decrease as the age of acquiring infection increases. So vaccination is definitely the key intervention to prevent the chronic HBV infection, since this commonly occurs following the infection during infancy and childhood. So childhood vaccination, the primary 3-dose vaccination, which we'll be going through in the next presentation, and the timely birth dose. These are mandatory as a key intervention to prevent the infection. Then a vaccination of the healthcare workers in certain high-risk groups. Apart from the vaccination, which is the core in prevention of HBV infection, other measures are to screen the blood and blood products, and to ensure the injection safety, occupational safety, and harm reduction interventions, and safe sexual practices. So if we see the infant 3-dose vaccination of hepatitis B in infancy, so first dose is administered at 1.5 months of age, 6 weeks after birth. So if with the single dose, it gives a protection of 16 to 40%, as opposed to when we have all the three, we administer all these 3 doses by 14 weeks, giving a 98 to 100% protection. So timely birth dose of hepatitis B vaccine is the key. We have to administer the first dose of hepatitis B vaccine, which is known as the 0 dose, within 24 hours of birth. And then nowadays we have these pentavalent vaccines where this hepatitis B is a part, so 6, 10, and 14 weeks, in addition to the first dose, which is the 0 within 24 hours. Then there's something called as anti-HBs titer. So if we get our titers checked in today's date, if we are not sure whether we were given hepatitis B vaccine during the infancy stage, or did you not take the adult vaccination, you can get your anti-HBs titer checked. So if the serum level is more or equal to 10, then it is said to be protective. It is used as a cutoff to define vaccine response in individuals. So over 90% of vaccine responders, they remain protected for at least 30 years, irrespective of whether anti-HBs antibody remains detectable or not. So booster doses of hepatitis B vaccines are generally not needed. Okay, so this is the vaccine coverage in the different regions. Then this is the impact of vaccine coverage on hepatitis B vaccine rate. So we see as we are passing through in time here till 2014. So the hepatitis B vaccine birth dose and till 3rd dose, that is the 14 weeks dose. So as it is increasing, the chronic infections are seeing the down curve here. So mother to child transmission in many endemic countries, majority of HPV burden is related to mother to child transmission at birth when we speak of hepatitis B virus. So, or due to other exposures during early infancy. So in India, like with the high birth rate and certain areas with the poor antenatal care or poor birth hygiene, and with the poor coverage of hepatitis B birth dose, and mother to child transmission remains the highest contributor to this. So testing of mother, if you must know that hepatitis B surface antigen HBsAg testing is mandatory in the antenatal period for the expecting mother. So this is the post-exposure prophylaxis. So Dr. Tushar will be taking it up in the next presentation. Then coming to hepatitis C virus routes of transmission. So speaking of hepatitis C virus, healthcare-associated infections are the most common, which are via unsafe blood and blood products, unsafe injections or endoscopic injuries, and other procedures, for example, dental treatment. Then sharing of needles among person who inject drugs. So the routes, if you see, are more or less common, but this is the most common route of transmission for HCV is healthcare associated. And if we talk about hepatitis B virus, so mother to child transmission, we see is the most common. Then tattoos, body piercings using contaminated equipments. So there are certain routes of transmission which are considered as low risk, like unprotected sex. It is low risk among HIV infected or male having sex with men having sex with men, MSM, and mother to child. Only 4 to 8% of babies they acquire HCV via positive HCV mother, unless the mother is HIV positive. So HCV route of transmission is lesser in mother to child as opposed to hepatitis B virus. And then sharing razors, toothbrush, close contact. So these are certain low risk routes of transmission. Then prevention strategies remains the same for HBV and HCV transmission. These are the prevention of parenteral transmission, the screening of blood and blood products, injection safety, harm reduction interventions, safe sexual practices and occupational safety. So no vaccine is yet available for hepatitis C virus as opposed to hepatitis B virus. So for Hep C infected persons, our mandate is to test and treat. So to test for early detection and treat them with the standard DAAs, which we say directly acting agents. So it's a 12-week treatment. So test and treat remains our cornerstone for hepatitis C virus. Then prevention of nosocomial transmission, that is hospital-acquired infections. So we have to ensure maintaining hand hygiene, surgical hand preparation, proper hand washing, use of gloves, and safe handling and disposal of sharps and biomedical waste as per the guidelines. Then training of health personnel about the modes of transmission and safe cleaning of equipment, screening of donated blood. So all this is coming again and again. So these are the modes of transmission for hepatitis B and C. Then prevention of HPV, HCV transmission in people who inject drugs. So awareness and availability of hepatitis B vaccination. So for adult immunization, it is 0, 1, 6 months. So if you take the hepatitis B vaccine today, then after 1 month, and then after 6 months from today. So this is the schedule for adult hepatitis B vaccination. Then provision of incentive, we can ensure this to increase the uptake and completion of hepatitis B vaccination series amongst adults. Then provision of sterile and syringes for harm reduction. And opioid substitution therapy to treat opioid dependence and to reduce HCV risk behavior and transmission due to drug injections. Then prevention of sexual transmission of HBV, HCV. We need to promote the use of correct use of condoms and consistent condom use, routine testing of sex workers in high prevalence settings, and integrated action to eliminate discrimination and gender violence. So this is the global health sector strategy document on viral hepatitis. So a page from that. So this was the baseline 2015 service coverage rates that we saw for Southeast Asian region. So our 2030 targets are to achieve 90% 3-dose hepatitis B vaccine, if you see in the first row, and 90% prevention of HPV through prevention from mother to child transmission, and to attain 100% blood safety. So the percentage of donation, blood donation screening, that we aim to achieve 100% screening by 2030, which we currently at, as per 2020 targets, we are at 95%. And we aim to reduce the percentage of unsafe injections to 0% by 2030. Maintain it, because 2020 targets show us that we have attained this number to be 0%. So to summarize, hepatitis B and C are parenterally transmitted. Hepatitis B infection in infancy and early childhood is particularly risky because of a higher risk of chronic infection, which in turn leads to many complications in adulthood. Then vaccination is an effective preventive measure for hepatitis B, particularly to prevent infection in early childhood. And birth dose followed by 2 additional doses has 90% efficacy in preventing mother to child transmission of hepatitis B. So this is birth dose followed by 2 additional doses, but the schedule is birth dose and 6, 10, and 14 weeks, 3 plus 1. And then anti-HBs titer if you are not sure whether you have received the vaccination in the infancy period or whether you have received vaccination in adulthood, you can get your anti-HBs titers checked. So if it is, the value is more than equal to 10, so it indicates adequate protection. Then safe blood transfusion practices, safe injection practices, and safe sexual practices are effective in preventing both hepatitis B and C. So thank you so much. Screen share. Thank you so much, ma'am, for such an enlightening presentation. I am sure it must have get rid of all the stigmas and the myths that we come across due to hepatitis. Being a dentist myself, I understand how the needle stick injuries and other things can cause hepatitis, but then it was much more enlightening and we all did learn a lot of new things. For our next speaker today, I would like to welcome Dr. Tushar Prabhakar. Dr. Tushar Prabhakar is a senior resident in the Department of Clinical Research and Epidemiology, ILBS. He graduated from University College of Medical Sciences, Delhi, and recently completed his post-graduation from Lady Hardinge Medical College. During his residency, he has worked in the fields of core patient management, essential drugs and medicines, health system strengthening, infectious and non-communicable disease epidemiology, reproductive women and child health, family planning services, malnutrition, and immunization activities. Sir, as a digital health specialist, was a departmental representative to assist and train members in LHMC for COVID-related data handling and operations at Delhi State Government's Data Management Portal and ComCare Delhi Fights Corona Portal. He is a creative enthusiast. He has won the first prize in numerous national conferences of IAPSM and IPHA for the best educational videos and best educational meme competitions. Over to you, sir.
Good afternoon. The topic given to me today is viral hepatitis B and C, screening, vaccination, and health education. So we'll be covering the topic under the following headings. We'll talk about screening, wherein we'll talk about whom to screen and the various screening tests available for hepatitis B and C. And then we'll touch upon vaccination, wherein we'll talk about the types of hepatitis B vaccine and the schedule for vaccination, what to do if somebody misses a dose of hepatitis B vaccine, and the overall coverage of hepatitis B vaccination, and the strategies to improve hepatitis B vaccine, especially the birth dose coverage. Finally, we'll touch upon health education and how it can impact on our road to elimination of hepatitis by 2030. So why focus on screening? So this is a graph given by WHO, which shows the cascade of viral hepatitis prevention, diagnosis, care, and treatment. So as we can see, of the total number of people who have hepatitis, only a few are actually getting tested and are aware of their status. So a low level of diagnosis of hepatitis B and C is a major bottleneck in the road to elimination by 2030. So we have already seen the key interventions to eliminate hepatitis B and C include firstly and primarily hepatitis B vaccination, which includes the birth dose and the 3 primary childhood doses. And then safe blood practices, safe injections, harm reduction. And I'll be touching in detail about hepatitis B and C diagnosis and treatment. So WHO Global Health Sector Strategy Service Care Delivery Target for Diagnosis showed that in order to eliminate hepatitis by 2030, of all the people who have hepatitis, by 2020, we need to be able to diagnose at least 30% of those. And by 2030, we need to increase that percentage to 90%. But as per reports of the WHO Southeast Asia region, the target achieved for Southeast Asia region, of which India is a part, for 2020, it was only 10% of hepatitis B people who were actually diagnosed. And of total people who have HCV, only 6.9% have been diagnosed. So as you see, this is by far lower than what the set target of 30% by 2020. So whom should we screen for hepatitis B and C? So as per the National Viral Hepatitis Program, screening services should be available at all peripheral institutions, which include health wellness centers and all the primary health centers. So anybody who walks in requesting to be tested or is referred from another institute or is expected to be a high risk patient should be he should be given the testing facility as these PHCs and health wellness centers. So, but if suppose we have a paucity of testing kits or they are lacking or in limited quantity, those who are at high risk should be given preference for screening. So who are these people who are at high risk? So these include expecting or pregnant mothers, people who use IV drugs, healthcare workers and frontline workers who work in hospital staff, people who are undergoing hemodialysis, and people having AIDS. So this is a picture of the screening test kit for hepatitis B and C. So these are called rapid diagnostic kits. So these are easily available and they are single-use disposable assays and simple to use. So this can be used by any worker or a staff functioning at a peripheral health center. They don't require additional reagents to detect or screen the hepatitis B or C. They can be easily read visually and they give a simple qualitative result within 30 minutes and they are cheap. They cost less than 50 rupees per unit. So the rapid diagnostic test kit for hepatitis B, we detect the HBs antigen, and for hepatitis C, we detect the anti-HCV antibodies. So as we can see, they have both these test kits have a high sensitivity and specificity. That means they are reliable. So if anybody undergoes screening using these kits, we can more or less confirm that they have hepatitis and they should be promptly referred to a higher center wherein we can do confirmatory tests and begin treatment. So vaccination. Essentially, we have vaccination only for hepatitis B, and for hepatitis C, studies are still going on whether to about developing a vaccine with hepatitis C. So as for hepatitis B vaccine, it's a recombinant subunit vaccine, which contains a viral protein, which is essentially a hepatitis B surface antigen. Previously, it used to be produced from plasma of people who with chronic HBV infection, but nowadays only recombinant protein is used. So the common types of hepatitis B vaccine that exist, either it can be monovalent or in combination with other vaccine preventable disease vaccines. So for monovalent vaccine, we have a vaccine called Engerix B. So as we can see, they are color coded and we have different vials for pediatric and adult doses. And For combination vaccine, under the government supply, we get it as a pentavalent vaccine, which has 5 components, and the other vaccine preventable diseases like diphtheria, tetanus, pertussis, and Haemophilus influenza B. If you go to a private setup, there's also an hexavalent vaccine, which has an additional injectable poliovirus. So it comes by the name of Inferix or Hexacin. So the vaccine schedule for newborns and infant is a bird dose or a 0 dose, which is the monovalent vaccine given within 24 hours of birth. And the primary 3-dose schedule, which is given at 6 weeks, 10 weeks, and 14 weeks after birth, which is the pentavalent vaccine under the government supply. Both these vaccines should be given in a dose of 0.5 ml intramuscularly. Whereas for adults, we can see that the dosing schedule is at 0 and then 1 month and at 6 months after the first dose. And it's a monovalent vaccine, which is given 1 ml intramuscularly. The vaccine protection. So the bird dose and followed by 2 doses of at 6 and 10 weeks, we can see that the mother to child transmission is reduced by almost 90% among women who have hepatitis B. And if a child gets 3 primary doses of vaccine of hepatitis B, the protection rate is almost 98 to 100%. So in case somebody misses a vaccine, under the universal immunization program, which India also follows, the bird dose should be given at birth, but can be given up to 24 hours after birth. And primary childhood doses at 6, 10, 14 weeks can be given up to 1 year of age, provided the duration between any 2 doses is at least 4 weeks. So if a person comes at 6 weeks and then 10 weeks and then misses the 14th week dose, so that child can come up to the age of 1 year. For adult immunization, only if first dose is taken, the second dose should be administered as soon as possible or when the person remembers. If the first and second dose has been taken and only the third dose is interrupted, it should be also taken as soon as possible, provided the interval between the second and third dose is at least 8 weeks. Sometimes we don't know, we are not sure, the person is not sure of the vaccination history. So when it's not reliable, extra dose of single antigen monovalent hepatitis B vaccine can be given as it's not harmful. So should we give hepatitis B vaccine in pregnancy? Yes, because neither pregnancy nor lactation should be considered a contraindication to vaccination. Especially pregnant women who are at risk of HBV. These include those who have had more than one sex partner during the previous 6 months, or are being evaluated or treated for an STD, or have had a recent or current usage of IV drugs, or have had a hepatitis B positive sex partner. We've already discussed this anti-HBs titer, so wherein we have said that a serum level of equal to or more than 10 milli international units per ml is protective. And this is used as a cutoff to the vaccine response. So especially in healthcare workers, when we are not sure, a person should get the HBs titer done first before going for adult immunization doses. And over 90% of vaccine responders remain protected for at least 30 years. As with any other vaccine, there are minor side effects or adverse events which can occur. And we can see that local pain, swelling, and redness and mild fever is commonly seen in around 3 per 100 people. Rarely we see that anaphylaxis, which is a severe hyperactive response, is seen in 1 per 1 million people. And if a person develops anaphylaxis to hepatitis B vaccine, further dosing of hepatitis B vaccine is contraindicated. So according to the WHO health strategy on viral hepatitis key service target, we can see that in order to achieve elimination by 2030, the coverage of primary 3-dose hepatitis B vaccine should be 90% by 2020 and by 2030 as well. Whereas the bird dose coverage should be around 50% by 2020 and 90% by 2030. So as of 2019, India stands at 24% among the primary 3-dose hepatitis B vaccine coverage, but only 56%, which is not much, because we have seen that overall we have to reach the percentage target of 90% by 2030. So why this low percentage for birth dose? Especially in India and other developing countries, there is a high prevalence of home deliveries. So the babies who are born at home, they miss the window for getting the birth dose. And also there are logistic issues in villages and peripheries where there is absence of cold chain maintenance for vaccine. So we have seen this graph already, where we are showing that as the age of infection increases, so the chance of having chronic hepatitis B decreases. So our aim should be to prevent occurrence of or contraction of hepatitis B at birth, or even any age below 5 years, because the younger the child, the higher the chances are of developing chronic infection. So what are we doing to tackle these birth dose deficiencies? So there's a thing called controlled temperature change approach. It's an innovative approach wherein the birth dose hepatitis B vaccine can be kept outside the traditional cold chain at room temperature for up to 3 days. And it is being tested for other heat stable vaccines, one of which is hepatitis B vaccine. So further studies will prove if this is a viable option to be used in peripheries and other outskirts and rural areas of India. Finally, we'll briefly touch upon health education and its role in elimination. So there are several strategies, which includes exhibition of posters and competitions among school children to raise awareness. Then having a stakeholder in the form of brand ambassador who can propagate the message for elimination of hepatitis, using social media to spread messages, endorsing campaigns, and having high level meetings with stakeholders at state and national level government institutes. So these are some of the posters released by ILBS. One talks about hepatitis B having a cure, and one talks about getting tested and vaccinated for hepatitis B during pregnancy, and the importance of birth dose, and some other general hepatitis B posters. ILBS had conducted a cartoon competition in 2019, which included participants from over 40 countries, and it helped propagating the message widely. And this is a campaign, Happy School, which included calling in all the government school principals and teachers for a one-day workshop at ILBS, and they in turn propagating the message of elimination to their peers and the students at schools. And this is an I Pledge campaign, wherein the project Empathy, we as a team ask people to pledge to take care of the liver and prevent occurrence of hepatitis and take the vaccinations on time. We have a brand ambassador, MC Maricom, and she helps us in propagating the message across the length and breadth of the country. There have been multiple meetings with conclaves with stakeholders at Parliament and which includes MPs and health ministers, so that the program can be included at a national level. And there are various faculty videos available on social media, YouTube, and there's a Facebook page and Twitter page wherein people can access and get regular updates regarding hepatitis B and its road to elimination. To summarize, the diagnosis is a key bottleneck. So we should focus on diagnosis, and this can be increased by screening as many people, especially the high-risk people. So these rapid diagnostic tests, they're easy to use, they provide quick results, they're cheap, they have high specificity and sensitivity. The primary 3-dose vaccines at 6, 10, and 14 weeks give a 98 to 100% protection to children. And birth dose and 2 primary doses decreases mother-to-child transmission by over 90% in women with hepatitis B. And anti-HBs titer of equal to more than 10 milli-international units per ml means adequate protection. Thank you.
Thank you so much, sir. Thank you. It is always a delight to hear your presentations, and in a very clear and effective way, your presentation did get the message through. I now request my colleague and a wonderful friend, Dr. Namrata Mohan to take the I pledge with us. Share kar dijiye.
Hello, everyone, and a very warm good evening to you all. Thank you so much for being connected with us. The I Pledge is a symbol of solidarity that we expect our colleagues, organizations working towards hepatitis B to show their support our fight and winning over hepatitis by coming together and fight the challenge collectively. For this, I request you all to kindly please raise your right hand and repeat after me. The I pledge is also displayed on your screen, so kindly repeat after me. I pledge that I will talk and generate dialogue about hepatitis B and C.
Pledge that I will talk and generate dialogue about hepatitis B and C.
May I also request you all to please unmute yourselves so that you're all audible to us. I pledge that I will spread awareness and educate people about hepatitis B and C.
I pledge that I will spread awareness and educate people about hepatitis B and C.
I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will try to get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you all.
Thank you so much, Namrata. We are heading towards the plenary session, the Q&A session. I can see that there are a number of questions and very interesting ones in the question box. I would request my speakers to come on board and help us answer those questions. So our first question for the day is,
While we had some active participations from our audiences and they have been posting questions, and our team has been very actively answering and addressing those queries. Some general questions that we've been having are on lines of hepatitis B virus. The first question is, how long does hepatitis B virus survive outside the body? And may I request Dr. Kaneka to kindly address this question?
hepatitis B virus stays for around 7 days a week, and hepatitis C stays viable for 4 days outside. You want to share your screen? Ye band kar dijiye.
Thank you, Dr. Kaneka, for addressing that query. The next query, and can hepatitis C positive mother breastfeed? Can I have Dr. Manya to answer that question?
Yeah, your voice was breaking, but I think the question was, can a woman breastfeed if she's hepatitis B positive, right?
Yes, that's correct.
Okay, yes. So breastfeeding is not contraindicated in hepatitis B. And yes, a woman can safely breastfeed if she's hepatitis B positive. Just she has to take care to prevent bleeding from cracked nipples. So yeah, so hepatitis B is not a contraindication, but be careful to prevent bleeding from any cracked nipples. That's it.
Thank you so much, Dr. Manya. The next question that we have is, what to do if I have missed second dose of hepatitis B vaccination? Should I go for the third dose, and when, or should I start the cycle from dose 1? Can we have Dr. Tushar to address, since he has very exhaustively covered this topic?
So if you have missed the first dose of vaccine, you can directly go for the second or third dose, whichever is pending, provided there's a gap of at least 4 weeks. You don't need to start from the first dose.
Okay, so Dr. Tushar, we have Saloni Lalwani asking a similar question on the same lines. Basic question, and that is, healthy people need vaccination against hepatitis B?
So essentially, the government says any child who is born should have the hepatitis B vaccine. So if an adult, or if most of us probably already have got in our, if we are fully immunized in the childhood, but if we are not, and even a healthy adult should get it. Firstly, or if you're unsure, you can probably first get your titers checked. If it is less than 10 units, then you should get it.
Also, just a gentle reminder once again, the post-webinar link has also been shared in the chat box. Please take a little while to answer the queries. The next question that we have, again, these are very general questions that we have broadly tried to put in here so that the general queries or the frequently asked questions are answered. The next question is, if a person is infected with hepatitis B virus, can the person still be vulnerable to contracting HCV and vice versa? Dr. Kaneka?
So HPV and HCV, so as we saw that the modes of transmission are more or less the same for HPV and HCV, that is the parental and HPV and HCV co-infections are also very common. So yes, if you are infected with HPV, you are still vulnerable to contracting HCV and vice versa.
Okay, so once again, you may just want to post all your queries in the Q&A box that you may be able to locate in your Zoom platform. All the questions that have been posted in the question and answer box have been addressed very actively by our speakers. So thank you, speakers, for that. And in case if you have few more queries, kindly post them in the Q&A box. One last question that we may take before we sign off is, I am a hepatitis B positive male. Can I plan my family and have a healthy child protected from HBV?
Yeah, if even if you are HBV positive male, then firstly the marriage counseling mandates you to get your partner checked. So they offer a panel of tests where you can check whether the female is HBs positive or not, and even if she's not positive first, then adult immunization, as we said, the schedule 0-1 6 months is mandatory for her. And as I said, there is a triple panel of tests which they get done, and when you are planning to plan for your family and you get your wife's HBsAg checked, then if it is positive or whether it is negative. So if it is negative, then nothing to do. You have to just take the regular precautions against the modes of transmission and go ahead with the normal routine vaccination in the infancy period. And if HBsAg, if the mother is HBsAg positive, so as Dr. Tushar said, so the baby needs to be immunized with immunoglobulin and the other vaccination as he has elaborated. So yeah, you can go ahead, plan your family, but these are the points that needs to be taken care of.
Thank you so much, Dr. Kaneka. Since we don't see any further queries coming in from our audience, I hope and I do believe that you have been able to get more insights and further in-depth knowledge regarding hepatitis B and hepatitis C infections. And our speakers have been wonderful in touching all the aspects very broadly about the hepatitis B and hepatitis C challenge that we are currently facing. So to know more about the challenge of HBV and HCV, I suggest you all to kindly go through the website, theempathycampaign.com. There is a knowledge repository that you may be able to locate in the website itself, which exhaustively covers all the aspects about hepatitis B and hepatitis C. So thank you so much for being actively participating in our session. And may I now hand over to Dr. Aisha.
Thank you, Dr. Namrata, and thank you all the speakers for answering the questions, the usual questions that are there, and also the posted in the Q&A box. Now I request Ms. Kritika Patil from United Way Mumbai to kindly give us the concluding remarks and the word of thanks.
Thank you for this opportunity. Honorable dignitaries and distinguished guests and dear participants, on behalf of United Way Mumbai and Institute of Liver and Biliary Science and its entire fraternity and organizing committee, I feel immense pleasure to take this opportunity to propose a vote of thanks. I take this opportunity to especially express my deep regards and gratitude to Dr. S.K. Saran, Vice Chancellor and founder of ILBS. Thank you for providing an opportunity to organize such event. I would further extend heartily thanks to all the speakers. First, Dr. Manya Prasad, Assistant Professor of Epidemiology. She rightly talked about the burden of HPV and HCV in our country. Extending thanks to Dr. Kaneka Kaushal, Assistant Professor of Epidemiology, for enlightening us on how transmission and prevention of HPV and HCV is at a community level. Further, we are grateful to Dr. Trishar Prabhakar, Senior Resident in Department of Clinic Research Epidemiology, for the information on the screening and vaccination strategy and health education for HPV and HCV at a community level. And I would also like to acknowledge our gratitude to Dr. Umesh, Professor and HOD of Epidemiology, and Dr. Rahul Kalot, Project Officer. A very hearty vote of thanks to all the speakers for gracing your important work and sharing with us your findings and opinions today. We are all inspired by your great words. My deep sense of appreciation and thank you to all participants, NGO, healthcare workers, NSS volunteers, students and professors who chose to be live with us and attended the webinar with a great enthusiasm and made it successful event. My sincere gratitude goes to United Way Mumbai team and organizing committee for taking that topics that really matters in today's age and time. Once again, thank you for all being with us this afternoon. Have a wonderful day ahead. Thank you so much.
Thank you so much, ma'am, for your kind and warm words. Now, I would request all of you to please fill the post-webinar link as well. It will be reflected on your screens. And there's also the link shared in the chat box. I request you to kindly fill that up in order for you to get the certificates. The certificates will be delivered to you in a couple of days, maximum 3 days. I hope the screen is visible to you all. I would also like to take this opportunity and thank United Way Mumbai in collaborating with us and hosting this webinar, in disseminating this knowledge among the masses, and also our eminent speakers for taking the time out, Dr. Wagle and Ms. Kritika Patil for speaking on such warm notes. I thank you all. For any queries, any feedbacks to be a part of empathy, I would request you all to get in touch with us at webinarilbs@gmail.com. We would be delighted to see your feedback. Any way you can incorporate yourself in the empathy campaign in helping us empowering people against hepatitis. Please do so. Thank you. I think that will be all for today. I request you all again to take the post-webinar survey. It will just take a couple of minutes. It will help us know what we have learned today, all of us. And that will be all from our side. Thank you so much. Certificates will be posted to you in 3 days in your mailboxes. Kindly keep those updated and keep checking. But it will take good 3 days. Thank you so much for your patience and time.